Howdy, y'all. This is Dr. Jarvis, and we have the great opportunity today to introduce you to Dr. John Scheinberg. He is a cardiologist who is now joining our practice as an Associate Medical Director for Tactical Affairs, which is something I just made up because I think it sounds kind of cool. Hopefully nobody knows what that means, and we can turn it into whatever we want to. I just think it sounds like a cabinet position or something. And maybe we'll do some vetting now. So, Dr. Scheinberg, welcome. Thank you very much for coming. Why don't you tell us a little bit about yourself?
So I am a board-certified cardiologist. I've been practicing here in Austin for going on 13 years now. I'm an invasive cardiologist. However, over the last several years, my practice has sort of migrated to a healthy preventative practice. My goal was to find people before they get sick and implement strategies to keep people healthy when we're beginning to see the early stages of heart disease, uncontrolled blood pressure, clinical cholesterol problems before these people manifest with heart attacks, strokes, hypertensive urgencies. And we have the ability in 2016, soon to be 2017, to identify an at-risk population early and to implement a very aggressive treatment strategy to keep these people healthy. So that's where I think medicine is going. It's better for the patients, it's better for the economy, and we have a limited healthcare dollar to begin with. And if we spend it wisely on aggressive prevention, we're able to keep people out of the hospital and let that dollar stretch a little bit further. So I'm happy to be here. I also have an interesting background. I'm a board-certified cardiologist. I'm very interested in clinical lipidology, so I focus a lot on lipids and just sat for the lipid boards. I'm also a police officer for the city of Cedar Park and a deputy U.S. Marshal. So hopefully I can bring to the agency here an understanding of risk analysis and reduction, treatment of chronic and acute cardiac issues, and help with the tactical medical program as it integrates within the different law enforcement agencies here in the Central Texas area.
So the main point of this discussion today is to talk about hypertension. So can you just tell us, to start off with, what is hypertension?
So it's a complex physiology, but it's very simple to kind of break down. So a good way of kind of getting an understanding of what hypertension is to understand that hypertension is basically a marker of what we call systemic vascular resistance. So the best way to think of hypertension or blood pressure in general, is the amount of resistance that the left ventricle has to overcome in order to pump blood. So if you have someone who has significantly high systemic vascular resistance, the arteries are clamped down, blood pressure is going to measure high, and the heart has to pump much more vigorously to force blood out. Now that creates a whole bunch of physiological problems, but that's the essential concept. If you have a heart that the arteries in which are dilated, blood pressure is low, the heart can unload with a lot less force. So the concept of hypertension should be thought of as the concept of resistance in the systemic circulation, not the pulmonary circulation, which is a pulmonary hypertension issue, but it is the concept of the resistance the left ventricle has to overcome in order to perfuse all the tissues.
So can we just define real quick, if you don't mind, the difference between preload and afterload? I think most people get it, but just to be clear.
Very simple. Afterload is defined as the amount of resistance that the ventricle has to overcome in order to perfuse the tissues. It's the resistance met in the arteries. Preload is the pressure and volume relationship in the left ventricle when the left ventricle fills. So it's really based on venous pressure. You can increase preload by increasing venous return back to the heart, but it's the pressure in the ventricle before the ventricle contracts. Afterload would be considered the pressure that the ventricle has to overcome to get blood to perfuse the peripheral tissues.
So that's really what the pre is discussing. Pre is what's coming into the ventricle, and then after is what you have to overcome to get it out.
Correct.
Okay. And so you were discussing hypertension as a manifestation of systemic vascular resistance. Really, you're talking about afterload there.
Correct. It's afterload.
Perfect.
Right.
Well, so that's what hypertension is. So why do we care about hypertension? Are there some complications? So
there are several complications. First off, as we age, blood pressure goes up over time. In fact, we used to call it essential hypertension. And if you go back and you look at some stuff that's not even that old, if you go back to, there's a famous picture of Churchill, Stalin, and Roosevelt at the conference at Yalta. And they're sitting there, and Roosevelt's smoking a cigarette, and his physician at that time documented his systolic blood pressure of 300. He soon died from a stroke afterwards, but it was thought that that 300 was needed. It was essential because as we age, our arteries harden, and we needed this hypertension to perfuse everything. So that's where the term essential hypertension happens. It's really it's a genetic issue, but it is almost a ubiquitous problem as we age. So hypertension is something we see throughout the population. It is genetically determined, but it is very widely seen.
Can you talk, I've heard terms essential and then primary and secondary hypertension. What's up with that?
So essential hypertension is the term that we use for primary hypertension.
Okay.
It's an outdated term.
So those are synonymous.
Yeah, we don't really use the term anymore. It's outdated. Okay. Primary hypertension is hypertension that exists in and of itself. There's nothing else driving it. Secondary hypertension is secondary to some other pathophysiological process.
So my renal artery stenosis is...
So, right,
okay.
There's basically if I haul off and kick you in the leg, your blood pressure is going to go up. That could be considered a secondary cause of hypertension. I get called to the emergency department all the time for people who have systolic pressure of 200 and they're passing a kidney stone. I mean, in the ultimate sense, it's really not a blood pressure problem. It's a pain problem.
Yeah.
So almost, I mean, even though it's not regarded that way, that's a secondary cause of hypertension.
Sure.
Any kind of duress. But in terms of chronic long-term hypertension, we think of basically two issues that cause significant labile or refractory hypertension. So hypertension that's difficult, that's up and down, or hypertension that's difficult to control. And those two conditions are blockages of the renal artery, so what we call renal artery stenosis, or an elusive beast called a pheochromocytoma, which is a little adrenaline-secreting tumor.
That was answer C on step one.
I've looked for that. I've looked for that little bugger for 20 years, probably 1,000 times, and I found 2 in 20 years. That's how rare it is. But the first time we don't check for it is the time that it exists. So it's a tumor that gives out squirts of adrenaline, drives up blood pressure. It is exceedingly rare, but it's possible. So now it almost doesn't matter, because if you have someone who's got prolonged hypertension, whether it's primary or secondary, or you have someone who's under a considerable amount of stress, we see people who have chronic pain that have elevated hypertension. They still manifest the problems that hypertension can cause. And those problems are varied, but typically cause increased risk of coronary disease because it increases shear forces on the arteries, increased risk for stroke, and the development of what we see as what we call hypertensive heart disease, which is thickening of the left ventricle, because the heart's a muscle. Any muscle that works against resistance hypertrophies. So those who lift weight, you go to the gym and you lift weights, the muscles get bigger because you're working against an increased load of resistance. Over time, if the arteries are constricted, the heart has to pump more vigorously, and we measure the thickness of the heart, and we actually see thickening. We actually see some changes occurring. First, there's problems with the heart, with its ability to relax. Then the heart septum, or the membrane that divides the left and right ventricle, will begin to thicken. And then you get concentric thickening of the heart, and it's a situation we call hypertensive heart disease. It is reversible if it's treated, but the problem that we see in that regard is we see young people who have a genetic predisposition to have hypertension that may develop it in their 20s. Most 20-year-olds don't go to the doctor unless they have in the military, or unless they have they're public safety workers and are mandated. But if you have a young college guy who gets out of college and gets a job and they feel well, a lot of times these people don't go to the doctor until they get to be 30s or 35, and you can conceptually have, and we see it all the time, someone who has hypertension for 10 to 15 years that's uncontrolled. Now these people have thickened ventricles. They have a significant cardiomyopathy, and a lot of times at that point, the ventricular function diminishes, and it's not reversible. So if it's caught early, it's reversible, but if it's gone for years, we develop a bunch of other problems, eye issues, kidney issues, and ventricle issues, which are sort of irreversible at that point.
So our paramedics are going to be talking to people in their homes and trying to explain to them why it's important that we control hypertension. Those would be the big things. So problem, you could go blind, your kidneys could fail, and you could end up on dialysis. You could have problems with a stroke. And I want to come back to that with stroke, because there are basically 2 types, hemorrhagic and ischemic. And I want to talk about how it affects those. The thing I always like to talk to men about who are just ignoring me anywhere else, can you think of anything that might grab a man's attention about why they could control
question. So, erectile dysfunction. So we see It's really interesting because when Viagra first hit the market in probably 2000, you have a group of people who had never sought medical care. Now you have a product advertised on TV that can cure erectile dysfunction, and it is highly touted as a miracle drug. So you have a group of people who've never sought medical care who now are going to the doctor.
Have a motivation.
Exactly. And these people have vascular disease. And what basically erectile...
Which is what they're trying to fix.
Right. Erectile dysfunction basically is poor pelvic perfusion.
Yeah.
And it is it's a manifestation or an end of the pathway of blood pressure, cholesterol problems, and diabetes. And what we learned by looking at this is that people who were coming in with erectile dysfunction had a significant amount of coronary disease, uncontrolled lipids, uncontrolled diabetes, and peripheral vascular disease. So Pfizer, who marketed, when they were non-generic, Lipitor and Viagra and Norvasc, now found this phenomenal way to detail their drugs to physicians that were saying, hey, the Viagra is going to, the concept of the need for Viagra is getting these people off the couch into the doctor's office, but now they're going to need Lipitor and Norvasc. And they even made a drug called Caduet, which is a combination of both of those drugs, marketed towards the same they marketed at the same time to the same population. So erectile dysfunction is a manifestation of vascular disease, which is made worse with hypertension.
So it turns out these pharmaceutical companies didn't get to be multi-billion-dollar enterprises for being stupid.
And well, the good news is it's all generic now, except Viagra. They actually just extended the Viagra patent. They keep finding more reasons to extend it. But yeah, they realize that they have an opportunity to get people off the couch into the doctor's office. Because if you tell someone, if you have hypertension, come see your doctor, it's not going to do it. But we can cure your erectile dysfunction. It's going to get people in the office.
Yeah, that's awesome. So I seem to remember a story behind how we actually discovered that Viagra helps. What was the story behind
Interesting.
that?
So Viagra was actually brought to market as an anti-anginal. That's how it was tested. And when they got to phase 3 clinical trials, the people who were given the drug versus the placebo reported this side effect. And there's actually a book written about it, and there's a group of patients who did not, or subjects, who didn't want to give the pills back.
Yeah. Talk to us a little bit about how Viagra works, because one of the things from the time where EMTs were taught, don't give it to people who have taken nitrates.
Right. So Viagra is a phosphodiesterase inhibitor. It's a PDE5 inhibitor. It inhibits a specific form of phosphodiesterase, which is a vasodilator, and the corpus cavernosal tissue happens to have more PDE5 in it. So it dilates all blood vessels. People who take Viagra see they get flushed, they see reported vision changes, and they have a drop in systolic pressure, but it also dilates the cavernosal blood vessels, the capillaries, and that causes erections, or improves the possibility of getting erections. Right. When you mix it with nitrates, you see a potentiation of the effect and a significant drop in blood pressure. Although it's not as dramatic as you would see in some of the TV shows where they have to rip the IV out because they're afraid. But and in fact, I don't advocate this, but sometimes we actually mix the two. And people have severe pulmonary hypertension, we'll use there's an off-label indication for using them both. We see it rarely, but there is a definitive contraindication in the literature with mixing nitrates and any of the PDE5 inhibitors, which are tadalafil, sildenafil, and vardenafil.
Pain is a cause for hypertension, so we see that constantly. We see people who have horrible headaches, and because they've heard high blood pressure causes headaches, they have a horrible headache, they take their blood pressure, it's elevated, so they come in expecting me to dramatically lower their blood pressure. What I typically do is I will sit there actually I tried initially explaining to them that high blood pressure doesn't cause headaches, and I realized that was a losing battle. So now what I do is I treat their blood pressure by treating their headache with drugs that do nothing to blood pressure. Their headaches feel better, and all of a sudden their blood pressure has dropped, and then I can have that discussion with them.
Exactly. That's very common. And we see it in people who have chronic back pain, for example. I have patients that have chronic, miserable back pain, and their blood pressure's up. The problem is when you see these people in the office and their blood pressure is very high, the inclination is to increase their antihypertensive therapy, and then when they're adequately treated for their pain, their blood pressure plummets. So in a secondary cause, you need to also focus on the secondary treatment, which in that case would be pain relief.
because otherwise you're not treating the underlying problem, you're treating a symptom of the pain.
And this is great because this is how I get to win my bingo game. There were people who doubted my ability to work ketamine into a conversation about blood pressure.
Okay.
So see, if you actually use ketamine, low-dose ketamine, to treat the back pain,
Right.
ketamine is an antihypertensive.
Correct. Analgesia in itself is an antihypertensive.
So somebody out there just won bingo for ketamine bingo. So going back to those patients who come in with their migraine, and what they're very worried about is their high blood pressure, they're worried that they're having a headache because their blood pressure is so high that their brain is going to explode and they're going to have a stroke. Can you talk to us a little bit about the role that untreated hypertension has in stroke?
Sure.
So what kind of strokes are we talking about, and what is the risk?
So there's a small group of people who have an underlying, typically congenital abnormality with aneurysm formation. In this small group, hypertensive urgency will lead to stroke, a cerebral aneurysm, even undiagnosed. The classic presentation of this is they're in an argument. They get worked up, their aneurysm ruptures, they have an intracranial bleed, intracranial hemorrhage, and then they have a massive intracranial pressure rise and stroke, and they die from it. And the worst part about that is they usually just got into an argument with someone.
Right.
So that is the minority of people. People who have healthy blood vessels in the brain, who do not, or I should rephrase that, people who don't have any aneurysm formation. Hypertension doesn't typically cause vessel rupture. What hypertension does is it is a component of atherosclerotic disease. We believe it increases the shear forces on the arteries, which causes plaque to develop at an increased rate. So people who have uncontrolled hypertension have an increased risk of plaque formation. And when you have an increased risk for plaque formation, you have an increased risk of develop occlusive vascular disease, whether it's peripheral vascular disease in the pelvis, lower legs, renal arteries, coronary arteries, carotid arteries, or intracranial arteries. So it is a risk factor for hypertension, but you're right, if we have someone who has significantly elevated blood pressure, they come to the office of 190, and they're not having mental status changes, they're not having vision changes, they're still urinating, they just have high blood pressure. Now, it does need to be treated acutely, but these people do not need acute emergent intervention. So back when you and I were training, one of the things that we used to do...
I was hoping we were going to talk about that.
Is procardia, sublingual procardia, which would drop the blood pressure precipitously. And it was treating us, not the patient. In fact, if you look at the data that came out of that, we were causing more problems. So we treat blood pressure...
Particularly the strokes that we were trying to prevent.
Exactly, because we now had acute hypoperfusion.
Right.
So when we see someone who has elevated blood pressure with no significant mental status or potential vision changes, so they're meditating well, they see well, and a lot of times these people, what will happen is they'll take their blood pressure, like, oh my God, it's 180. I'm going to go to the emergency room. Or they take it, it's okay, take it in, oh my God, now it's 190. Oh my God, and they take it in, oh, it's 200, and they get to the emergency room, and by the time they get to the emergency room, they've had a 20-minute car ride in which they didn't take their blood pressure.
Right.
They finally get there, and now it's 170 again, and they're given a little bit of lisinopril, blood pressure comes down, and they go home.
Yep.
So it becomes a sort of it ramps on itself.
It's a self-fulfilling prophecy.
Exactly.
Yeah.
So the acute treatment of hypertension is very different from the treatment of a hypertensive urgency or hypertensive emergency.
I found that my best treatment for hypertension is compazine or Reglan, because it helps fix their headache, which lowers the blood pressure.
So if you have a headache, the question is what comes first. Most people think the blood pressure causes the headache, but in reality, I agree 100% that the headache oftentimes, in and of itself, causes the hypertension because it's painful, it's stressful, and then they take their blood pressure, now it's high, which manifests more stress and anxiety, which causes a cascading effect.
Let's go back to the stroke, it being a risk factor because it is a manifestation of atherosclerotic heart disease.
It's one of the causative factors of atherosclerotic disease.
So it seems like the idea here is you get some narrowing in those arteries.
Right.
That sounds familiar, like we're seeing that exact pathophysiology in another body part, like in the heart.
Right. So the development of atherosclerotic disease is a universal process. Now, some arteries are more resistant to it than others, and we don't really know why that is. For example, when we do bypass surgery, the left internal mammary artery is highly resistant to atherosclerotic disease. As soon as we crack that code and we can replicate what is different in that artery, we should have a whole new line of therapy. for coronary disease.
I didn't know that. So I always thought the reason they used the Lima is because, well, geography, it's
exactly,
it's
but
close
it's
by.
also very rare to get
Interesting.
atherosclerotic disease in the artery.
I didn't know that.
And we don't know why. But so some arteries are more resistant than others. But overall, if you create the underlying causes, smoking, diabetes, dyslipidemia, hypertension, and you check arterial beds, you will see plaque everywhere. So and the best example of this is someone who comes in with a stroke, more often than not, they have coronary disease. Someone who presents with a heart attack or need for a stent, more often than not, they have carotid disease or peripheral vascular disease. They run hand in hand.
It's probably the reason that the Heart Association is so involved with stroke prevention now.
Exactly. It's a global problem. Exactly. And the underlying, the difference would be, we see when someone has a heart attack, it's not, and this is a very big misconception. When someone has a heart attack, we're not looking at progression of atherosclerotic disease when a blockage goes 30, 40, 60, 80, 90, 100, heart attack. Right. It's a concept of plaque rupture physiology with inflammation and clot formation. So we see plaque rupture, but we can see plaque rupture in every blood vessel, but we also see as plaque continues to progress and you have decreased perfusion, you also have these areas called watershed areas, which are just areas that are not well perfused by one blood vessel. They sort of lie in between two different areas that get its blood supply from both areas. And if there's an area of the brain that is partially perfused by one and partially perfused by another arterial territory, and you decrease blood flow in both of those, this area is going to be thirsty for blood. So when people usually have strokes, if it is a chronic atherosclerotic process, and we scan these folks' heads, we see oftentimes not one area, but multiple little areas that are not getting perfused. This is very different than people who have an embolic phenomenon. So if there is significant atherosclerotic plaque in the carotids, or there's something in the heart that shouldn't be there, a tumor, a thrombus, or an abnormality in the heart rhythm which causes the development of sluggish blood flow and thrombus, we can see embolic events. So we can see on an MRI the presence of embolic showers, which also cause strokes. So you can have embolic stroke, you can have what we call ischemic penumbra, so an area of the brain that's not getting enough blood because it's sort of in between two different distributions, or you can have a hemorrhagic stroke in which you have a artery that is basically rupturing, causing bleed, and you can have an embolic stroke which converts to a hemorrhagic stroke. So the concept of stroke is...
Right after we treat it.
Exactly. So it's a complex process of multiple different manifestations, but hypertension is an underlying player in every one of those potential problems.
We said that if you have one episode, you get kicked in the shin, your blood pressure goes up. That's not really a risk factor for stroke. Your head's not going to explode. So how long are we talking about before these complications manifest themselves?
So it depends on the complication. So for example, left ventricular hypertrophy. Again, this is based on 20 years of clinical practice. We see the development of changes in ventricular function and thickness within probably a year of getting hypertension. And it's subtle, but we're measuring the difference between a millimeter. So we measure the interventricular septum and the posterior free wall of the heart. They should measure about 1.0 to 1.1 centimeters. We'll see the development to 1.2, 1.3 within a year's time if the blood pressure is poorly treated, especially as our patients get older. But the good news is we see resolution within the same amount of time frame. So if we see someone who has a thickened heart and we get them on the appropriate therapy, that thickness resolves and their ventricle improves. So it is reversible. And in terms of atherosclerotic disease, the concept is a concept we call response to retention. And basically what that simply is we know over time, atherosclerotic disease is primarily a lipid disease. We have data going back to Vietnam, even Korea, where young 18-year-old soldiers who are killed and in battle, and they're brought back, and autopsies and necropsies are done, and they find atherosclerotic disease in those people. So it is a response to retention of lipids over lifetime made worse with underlying hypertension, underlying diabetes, tobacco use, things of that nature.
Tell us a little bit about staging of hypertension.
So I will tell you, staging of hypertension is an academic.
And how useful that is.
Yeah, so it's useful in terms of classifying it in large trials, in discussing it. But when it comes down to a clinical analysis, we don't necessarily treat prehypertension, different than stage 1, different than stage 2. So just for the definition, prehypertension is considered hypertension with a systolic of 120 to 139 and or a diastolic between 80 89. Stage 1 is the next stage, which is going to be 140 to 159, 90 to 99 diastolic, and then stage 2 is 116 above or 100 and above diastolic. But I would argue that in a clinical practice, if I have someone who comes in who has what we would consider prehypertension, a systolic of 130, 135, and we look at that person's ventricle and they have evidence of left ventricular hypertrophy, we're going to use medical therapy on that person. Conversely, if I have someone who comes in who's got a blood pressure of 145, and we look at their ventricle and they have no evidence of left ventricular hypertrophy and maybe have manifested no coronary disease, and I have a person who is a smoker, who's overweight and sedentary, I'm going to try lifestyle modification on that person before I put that person on medication, because we're not yet seeing the manifestations, the downstream sequelae of hypertension in that person. So there are staging parameters that are there, but I would argue that it's an academic pursuit and it falls a little bit in the clinical practice.
I think if we want to understand what high blood pressure is and how it goes awry, it may be helpful to understand what blood pressure is there for and what the normal physiology is. So can you talk to us a little bit about what the normal blood pressure regulation is?
Human beings that walk the earth on 2 legs as opposed to being on all 4 legs, we have a sort of need to keep blood pressure up, because if we stood up and gravity took its course, all blood would go to the lower legs and we'd pass out. That, as a matter of fact, that's a concept called autonomic dysfunction, which we see quite a bit as we age and as people develop nerve issues with diabetes and whatnot. So a blood pressure regulatory response has to do with several different things. In sort of a 50,000-foot overview, it has to do with the amount of fluid in your system, because if you were to consume too much sodium, drink too much water, your blood volume increases, and you have to have a way to get rid of that extra fluid. So blood pressure is also tied into volume, intravascular volume. Blood pressure is tied into a neurogenic response, because baroreceptors in the neck and stretch receptors in the heart regulate sort of arterial tone. So we know we go from a lying position to a standing position. So we have all these underlying mechanisms which are designed to keep blood pressure in an appropriate range so we don't pass out. Because if you are volume deplete or volume overloaded, they manifest with lightheaded, dizziness, or inability to breathe because you have too much fluid. So we've developed these natural mechanisms over millions of years of evolution to sort of regulate blood pressure. Sort of an overview. Blood pressure is regulated basically by the kidneys. The kidneys control, from a simple standpoint, the liver produces a peptide called angiotensinogen, which is converted through a hormone called renin, secreted by the kidneys, to angiotensin 1. Angiotensin 1 goes to the lungs. It's converted to angiotensin 2. And basically, angiotensin 2 is a chemical that travels the body, causes the adrenal glands to release aldosterone, which controls fluid by regulating sodium retention, and causes the arteries to constrict. So the kidneys are the primary organ that control blood pressure. And problems can occur at every one of those levels. And from a pharmacological standpoint, we can intervene at multiple levels within that sort of renal renin-aldosterone system to reduce blood pressure, should it go awry.
Well, let's talk a little bit about, though, the pathophys, how it goes awry. So how can some of those systems, you had mentioned one, renal artery stenosis,
right?
How that can interfere.
That's probably the best example, because the other, as we age, we used to call it hardening of the arteries. The arteries are not PVC pipes. They're not rigid structures. They're alive. They dilate and they flex. And as we age, we lose the artery's ability to do that. So blood pressure is transmitted better, or worse in that case, in arteries that are calcified and hardened. But the best example, sort of, to understand this mechanism a little bit better, if we have a patient that has a blockage to the kidney. So each kidney is essentially fed by one blood vessel called the renal artery. Some people have 2, but more often it's just one artery. If there's a blockage, an atherosclerotic plaque or a blockage in the artery, or hyperplasia of the intimal tissue, which we call fibromuscular dysplasia, the kidney's not getting enough blood. So the kidney thinks, I hate to dumb it down, but the kidney thinks that blood pressure is low. because the restriction to flow is not letting enough blood hit the kidney. The kidney responds to that by releasing all the hormones of the blood, by driving up the renin system, which causes increase in angiotensin II, which causes increase in aldosterone, and that causes blood pressure to go up. The hallmark of that condition, though, is as blood pressure goes up, now blood pressure is higher, it can get through the atherosclerotic disease, kidney sees enough blood pressure, it stops releasing these hormones. So one of the hallmarks of renal artery stenosis is this labile up and down blood pressure that swings all over the place. But that's sort of a good concrete example. And in that case, if you fix the underlying problem, oftentimes you'll fix the hypertension. That's an oversimplification, because if this has been there for a while, even if you if you put a stent in the renal artery, you still see this hyperactivation of the renin system. So it doesn't work if it's not caught quickly. So
the renal artery stenosis gave us a good reason to talk about the kidney involvement, but let's go back to the pheochromocytoma, and or the pheochromocytomas that we see every day, which are people doing cocaine and stimulants.
Right.
How does that interact with blood pressure and cause hypertension?
So if you talk about a pure adrenaline-secreting tumor, the manifestation of that clinically is the tumors do not release a level of adrenaline on a steady state. It pulses the adrenaline. So the adrenaline builds up, it's ejected out of the tumor. So these people who have pheochromocytomas have normal blood pressure, and all of a sudden they get a squirt of adrenaline, which drives up blood pressure, drives up heart rate, and it's very, a young doctor will make a lot of mistakes because it's very consistent with what a panic disorder is, panic attack. So someone has a panic attack, and I fell in this trap as a young doctor myself, where you see someone who says, oh my God, I'm sitting fine, all of a sudden my heart starts pounding, and I check my blood pressure, it's up. My gosh,
and I'm breathing fast, and all the other manifestations of panic attack.
You have a pheochromocytoma, and we do a 24-hour urine collection for metanephrines, and we look for all the byproducts of adrenaline, and they're not there. And then if we really believe it, we'll scan their abdomens, we'll look for evidence of hyperplasia of the adrenal glands, or we don't see it. So panic attacks look similar, but a pheochromocytoma is a true adrenaline-secreting tumor that's a surgical disease. It needs to be removed, but they're very rare.
The substance abusers, the folks doing the stimulants,
right.
Cocaine or methamphetamines, that seems like that would affect blood pressure in the same way a pheo would.
It does. It's their sort of, there's some pathomimetics. It's adrenaline. So it activates the alpha and beta receptors on all the tissues. So you get an increased heart rate, you get vasoconstriction, and you get an increase in contractility. So cardiac output is going to go up because you have an increased heart rate and an increased contractility. You have increased systemic vascular resistance, and it doesn't matter whether it's Sudafed, whether it's cocaine, methamphetamine, panic attack, or the manifestations of a true pheochromocytoma. Clinically, they look the same. The differential diagnosis is really on taking a history. Oh, you're using cocaine? Okay, I don't think you have a pheochromocytoma.
Right, exactly.
That's sort of the...
Perhaps a treatment suggests itself.
Exactly. But we fall in that trap all the time, but it's very easy to exclude. And I will tell you, the first time we don't exclude it is the time we miss it.
Well, can you talk to us a little bit about classifications of antihypertensive medicines?
I will say right off the cuff that treating hypertension is an art. And if I have a patient that comes to see me for antihypertensive therapy, I sort of have my mainstay of drugs that I use. That person goes to see a different physician. He or she may have a different sort of first line use of drugs. In certain patients, there's an overwhelming need for one type of drug. And if you look at some of the recommendations, they'll recommend things like diuretics up front. However, if you have someone who does not have heart failure, does not have coronary disease, there are a lot of good choices. And I always tell the patients, it is a trial and error process, and there's 3 balls that we have to juggle when we're treating hypertension. The drug has to be effective, it has to have little or tolerable side effects, and it has to not break the bank. So I can get 2 out of the 3 very quickly. The third one is always the challenge. But, and I always tell the patients, well, I have more drugs than you have hypertension. I can get your blood pressure controlled, but I have to get it controlled in a fashion that is not going to control it, drop it too aggressively because the side effects go up. I want to use agents that are not going to cost you $200 a month and I want to find agents that don't make you sick. So there are several different classes, and each class has its benefits and disadvantages. The beta blockers mainstay have been around for a long time. They work beautifully. Some of the older beta blockers cross the blood-brain barrier, and they cause fatigue, weight gain, depression at higher doses. So in a young, healthy person, beta blockers are not the greatest drug. In males, they also can cause erectile dysfunction. They work, but the side effect profile tends to be higher.
So what are the main beta blockers that you would see used
So
for hypertension?
So the non-cardioselective ones, Inderal, propranolol, metoprolol, either succinate or tartrate, the tartrate being the short-acting that needs to be given twice a day. There are carvedilol, which has got some alpha-blocking characteristics with it, which is another adrenaline receptor. Carvedilol is a twice-a-day drug, although there is a once-a-day carvedilol. However, it's now generic, but has never been able to be replicated. So the once-a-day carvedilol is 5 times more expensive than the $5 a month generic carvedilol. Some of the newer beta blockers that are more cardioselective that don't cross the blood-brain barrier are medicines like Bistolic. Bistolic also has a vasodilator effect. So the medicines are good typically in young, healthy people. They cause, like I said, fatigue, weight gain, depression, erectile dysfunction. In our older patients who have coronary disease or heart failure, they're mainstays of therapy.
So one thing I want to point out, and this is from personal experience on what not to do. I was on a beta blocker and was on a long trip. I'm a runner. I ran out. I just stopped taking it cold turkey. So because beta blockers can cause some side effects, some of our patients may be tempted to just stop taking beta blockers.
Huge mistake.
Why is that?
Because beta blockers block the beta receptors. So if, from a theoretical purpose, if you have a cell that has 5, this is a theoretical, 5 beta receptors, 5 adrenaline beta receptors, and you give that person a beta blocker and you block 3 of those receptors, now the person has 2 receptors. If you stop, so you have 2 receptors, the body sees that there's only 2 receptors. So it creates more beta receptors. It upregulates the beta receptors. So you had 5, now you have 2. Your body starts producing more receptors. And all of a sudden, if you remove the beta blocker, instead of having 5, now you have 7 or 8. So people who abruptly stop beta blockers will feel palpitations, hypertension, jittery. It's a terrible feeling. Now, you can stop beta blockade on people, but it needs to be weaned off slowly. So if you have someone who either decides they want to self-discontinue this medication or runs out, they'll feel bad, until their body downregulates their own beta receptors. And it's a terrible feeling.
Yeah, it sucked. So as a discussion about that, if you have a patient who wants to stop beta blockers, we should probably have this conversation with them about this is very likely to happen. Make sure you talk to your doctor. If we're in a situation where they've just run out, they have no interest in stopping it. They've just run out. They're feeling like crap. That doesn't necessarily mean they have to go to the emergency department. This is one of these situations you can call me and I'll call in a prescription to tide them over until they can get back in and see their doctor.
Exactly. And then the other thing is if the beta blocker is being used for coronary disease or heart failure, stopping it's going to cause an exacerbation of coronary disease, so chest pain, and it can cause an exacerbation of heart failure.
You had started to talk about calcium channel blockers.
So calcium channel blockers block the calcium receptors, and what you end up seeing in calcium channel blockers is vasodilation. And there's dihydropyridine calcium channel blockers, which work on the peripheral arteries more, and then there's the non-dihydropyridine, so that would be example of the dihydropyridines would be amlodipine, which is Norvasc, Procardia, which is nifedipine. So we see they usually end in pine. So the dihydropyridines are peripheral acting calcium channel blockers. The non-dihydropyridines are things like verapamil and cardizem, which also dilate blood vessels, but also can cause negative chronotropic and ionotropic responses, which means it causes the heart to beat slower and potentially the heart to beat weaker. So we use them in different categories. In my experience, things like diltiazem and verapamil to use those as primary antihypertensive tend to cause more side effects. The dihydropyridines tend to be very well tolerated. The manufacturer, when Norvasc when amlodipine was branded as Norvasc, Pfizer had said that 7.5% of the people who took it got peripheral edema. I think it's more like 15% or even higher in some populations. So the side effects we see with those are usually peripheral edema, and it can be pretty significant. So we use these medications all the time as rate control medications in people who have atrial fibrillation. We use them in people who have supraventricular tachycardias to modify AV nodal pathways, so it changes conduction. We use them in people who have hypertrophic cardiomyopathies because they're negative inotropes. They cause the heart to squeeze less. So these medicines have other uses. Matter of fact, in my practice, the majority of their use is not in hypertension, although they are antihypertensives. There are medications which target the renin-angiotensin system, so there's angiotensin-converting enzyme inhibitors, which are the first manifestation of that type of medication. These medicines are old. They work beautifully. Matter of fact, when I was in the military, some of the antihypertensives, which were ACE inhibitors, we could give to the pilots, and they wouldn't have to go through waiver process because the side effects were so low. In fact, medicines like lisinopril and ramipril, the biggest side effect is cough. And we see that in just a small subset of the patients, but they're very well tolerated.
And that's not going to make you crash a plane.
It's not going to make you crash. Well, hopefully not.
That'd be a bad cough.
Then there's the second generation with the angiotensin receptor blockers, which are medicines which we call the ARBs. And they're losartan, valsartan. A lot of those are generic as well now. Highly effective. They're usually paired with diuretics because the diuretics potentiate their effect. There is a third generation, which was called Tecturna, which was an angiotensin blocking drug. Just got pulled off the market a few years, about a year and a half ago, so we don't use that medication anymore. But the ACE inhibitors and the ARBs work beautifully, and they're generic, they have high tolerability profiles, and they're very effective, and you'll see that quite a bit.
Now, this may not be true anymore, but when I was in medical school, they talked a lot about the remodeling effects of ACE inhibitors.
Right.
And at the time, they didn't know whether the ARBs would do that. Any change in that?
So some ARBs are now approved in heart failure for remodeling. Anacan is one of them.
Okay.
So the ARBs do it. We assume a lot of times it's a class effect, although we definitively know the ACE inhibitors remodel. And those are the primary drugs that we still use in people who have had MIs and people who have heart failure. The next class of medication would be the pure vasodilators, hydralazine, minoxidil, which works beautifully, as we all know is Rogaine.
Right. Another great story about how a product came to market.
Exactly. So minoxidil is a go. If I have someone who has resistant refractory hypertension, we put them on minoxidil, but they have to be paired just with beta blockers and diuretics because they cause palpitations, tachycardia, and they cause edema. So you cannot use minoxidil without a beta blocker and a diuretic, but it works beautifully. Hydralazine works that way.
Well, you mentioned diuretics. Can you tell us a little bit about the different classes, particularly with their effects on potassium?
So there's thiazide diuretics, there's loop diuretics, and there's potassium-sparing diuretics. The loop diuretics are diuretics like Lasix, Bumex. Those medications although they do lower blood pressure, I'm not a fan of using those medications as blood pressure medications. They cause potassium loss, and as far as I'm concerned, when Lasix is prescribed or Bumex, it needs to be prescribed with a potassium supplement because we always get into problems, especially in acute use. The thiazides, irrespective of what is sort of written in the textbook, it's a yes or a no. And I don't know why this is, but I have some patients who do not become deplete with potassium on thiazides and others who do. So when I prescribe a thiazide diuretic, it's reasonable to check a Chem7 and look at potassium levels within 30 days. And we'll see some people become incredibly hypokalemic with low potassium, other people don't. Just as some people with thiazide diuretic will become hyponatremic, they'll drop their sodium, especially if they become incredibly volume depleted. It's hit or miss. And the potassium-sparing diuretics, like triamterene, can be paired with a thiazide diuretic, and we don't see potassium loss in those people. So we have a situation in which when you're messing with diuretics, although they are effective at lowering blood pressure, they also can mess up renal function, they can mess up electrolytes, they can cause volume depletion. So those need to be monitored a little bit better. In a young, healthy person who gets a little bit of edema and their rings are tight, not so much. But in our elderly population, those people do need routine chemistries to make sure that they're not developing any electrolyte problems.
So this we have a question later on about how you tailor treatment to different groups, but that kind of makes sense if you're thinking about, well, the diuretics are working on the kidneys. If you have renal dysfunction, then that may not be the best agent to use.
Potentially, because you can have someone who has renal dysfunction and absolutely have a need for a diuretic, someone who has heart failure. These are people who have had to take the example from earlier, years of uncontrolled hypertension, years of atherosclerotic disease. Now they have significant volume overload. Even though we have a potential problem with renal function, these people need ACE inhibitors if their heart functions are weakened. They need diuretics. You don't die from renal failure. You get dialysis from renal failure. You die from heart failure. So a lot of times you end up trading one problem for another, and it's a fine walk. And what we find is our patients who have renal insufficiency and heart disease, they walk a very fine line between being volume overloaded and volume deplete. And they go back and forth. So in that population, a very good sort of manifestation of effective therapy is we look at daily weights, and we prescribe diuretics to be used on an as-needed basis, not on a continual basis. If they gain more than 3 or 4 pounds in a day or two, their diuretics go on board for a day or two until they're back to their dry weight. And some people who have a hard time with that will say, okay, you'll take a diuretic Monday, Wednesday, and Friday, and we'll intermittently pulse a diuretic. So it is a double-edged sword. You have someone who has renal failure, but they're volume overloaded. There's really no option. You've got to get the fluid off, and a lot of times it does exacerbate renal disease.
So I get questions with my CHF patients where they're on a certain amount of Lasix, and let's say they're on 100 total a day of Lasix, and they will also have Maxide, or they'll have another diuretic to pulse. Any particular guidelines on when, for me, if anybody else or my paramedics call and say, well, they're on this, they have some Maxide, should we increase the Maxide or should we increase the Lasix?
So,
and I realize there's not a science-based answer
there's not,
to this.
but I'll tell you, it is an experience thing. I find what ends up happening, so to answer that question a little bit more thoroughly, what ends up happening is your body attenuates to the diuretics. So you have these people who are on 40 milligrams of furosemide every day, and now they get volume overload. Well, if I took 40 milligrams of furosemide without having been exposed to it, I'm going to pee my brains out. These people, 40 milligrams is causing no increased diuresis. So we typically go from 40 to 80. Then they hit a plateau. Then we go from 80 to 160. And the diuretics tend to be ineffective. What we do in that case is switch to a different loop diuretic like Bumex, which is a little more effective. But what I will typically do is give Zeroxyl, metalizone, which is a really crummy diuretic by itself. But if you give it 30 minutes prior to a Lasix dose, it primes the kidney for the Lasix, and there's a tremendous diuretic effect with Lasix. So in those people, what I will typically do in those people is keep them at a very low dose of Lasix. Once we compensate them, keep them at a very low dose of furosemide or Lasix daily for a heart failure patient, for example, and have an algorithm for them that if they gain more than 5 pounds, they double their Lasix. If that doesn't work, then they'll add metalizone 2.5 or 5 milligrams 30 minutes before the Lasix until they get back to their dry weight. The problem is, again, a lot of these people will overshoot, and now they become volume deplete, hyponatremic, and they end up in the emergency department because they have exactly the other signs. So it's a very careful balance. There's a class of medication called alpha blockers, but about 10 years ago, we learned that these medicines are not good primary antihypertensives. They work for reduction of prostate size. They work for urinary retention. They have a blood, like this is Cardura, which is doxazocin, those type of medications, but they cause more problems than they help with when used alone for antihypertensive therapy.
I used to prescribe them for kidney stones. The thought is that they would cause some dilation of the smooth muscle around the ureters. That would help the stone pass, but what would happen is they would stand up, and now we would see them for their broken hip.
Right. There's an art to seeing what works, and it's a practitioner pattern to see. Some people will start one drug, maximize it before they initiate a second drug. Other people will use 2 drugs in combination. There's no right answer. The right answer is to check with the patient to make sure it works, they can afford it, and it's not causing side effects which are intolerable.
Sort of a negotiation both with the patient's wallet, the patient's preferences, and the patient's physiology.
Because compliance isn't going to work. If it's too expensive, or if I have a patient who takes a drug, every time they take it, they can't stand up without getting dizzy, they're not going to take their medication. So it has to work. And if it's $200 a month, and let me tell you something else, and this is good for the paramedics to know, this is a very difficult topic to broach with the patients. Very rarely will a patient sort of offer up the fact that they can't afford their medicine. So it's very important. And when I teach other doctors, I tell them, you have to ask the patient, is this affordable? Because if you don't bridge that topic, a lot of patients won't. And I'll ask that question every time.
It's a matter of pride.
I say, yeah, I'm in my donut hole, or yeah, it's $150. And that affordable is a sliding scale. Everyone's different. So I never ask, how much is this medicine? Because when I prescribe it, I can't tell if it's going to be covered or not.
Right.
But I'll ask, is this something that's affordable? Is it easy to afford? Because if it's not, I may not even know it. And I may just use that drug. The best example, which is not hypertensive, are the novel anticoagulants, with Eliquis, Pradaxa, Xarelto, Savesa. I may prescribe Xarelto because it's once a day. It's what I think to be the easiest. In reality, that person's insurance would prefer Pradaxa. The Xarelto is $150 a month, the Pradaxa is $20. But I don't know this unless we ask.
So we talked a little bit about using drugs, which is great if you don't have other options or if you own stock in a pharmaceutical company. Right. Let's talk about some of the things that you can do to manage high blood pressure that we should probably all be doing anyway. Dietary modifications, lifestyle.
So let me first start by saying blood pressure is a genetic problem. So we have people who do everything right, I have thin, marathon running vegans who have hypertension. And at the same token, I have morbidly obese diabetic smokers who have normal blood pressure, and everything in between. So what I've learned is if you have a predilection or a proclivity to have hypertension, you're going to have hypertension. However, it doesn't mean it has to be treated with multiple drugs. So if we have someone who is developing pre-hypertension or even stage 1 hypertension, and they have no atherosclerotic disease, they have no LVH, no thickening of their ventricle, and they're sedentary, they have poor dietary habits of too much sodium and too much glucose, because uric acid, which is a byproduct of glucose metabolization, causes increase in vasotone. We'll put those people on an exercise regimen, and we'll put those people on a diet which is low in glucose. The sodium is still a manifestation, although I'm not convinced dietary sodium plays much of a role, because if there's healthy kidneys, your body mobilizes the sodium and you swell for a little while, but then you eliminate it. But we put these people on diets which are low in sugar and increase their exercise. And the recommendations for exercise now are huge, 200 minutes a week, which is almost impossible for most people to hit. Not you, of course, but for most people. But we can see with
as long as the only thing we count is cardio.
If we look at exercise and diet with a reduction of weight of about 10%, a lot of times we can forego the need, at least immediately, for antihypertensive therapy. And if I have people who are on 2 or 3 agents, a lot of times I can wean the drugs to get them down to 1 agent. So lifestyle is huge. But I also have to make sure I tell people hypertension a lot of times cannot be completely treated with lifestyle modification. Look at it as adjunctive therapy, along with the right drug.
So we had some questions about, I guess, the permanence of the need for treatment. So let's say that you have someone, and here we're going to exclude people with other chronic diseases. So relatively healthy people, maybe overweight, may have really crappy lifestyle choices, but they have high blood pressure. Does that mean that you're going to have to, you kind of mentioned this, that doesn't necessarily mean they're going to have to be on antihypertensives the rest of their life?
They need to be monitored, because also 2 things are going to happen. This person could potentially get healthier, which would drop their need for antihypertensive therapy, but they're also going to age, which is going to increase their need for antihypertensive therapy. So the problem from a pragmatic standpoint is once someone is on antihypertensive therapy, it's hard to get them off it. It's not impossible, but so I don't like to initiate therapy unless we've tried everything else if there's no underlying problem.
So since we're talking about treating blood pressure, what are the general goals for hypertension management?
So I will categorically say I like to treat everybody into the 120/80 range, with a couple of exceptions. There's a big problem, and you and I had talked about this earlier, in which we need to treat the individual, not the blood pressure. And this is another problem that a lot of doctors, especially the younger, less experienced physicians, will make, and that is they'll have an elderly patient who's got a blood pressure of 170, and they will throw more and more drugs onto that person until the blood pressure is 128. But now you have 4 new medicines. This elderly person is lightheaded, dizzy, a fall risk, constipated, and you've made that person's life worse. You fix the blood pressure, but the individual is worse. Right. So it's a fine balance. So I would set a goal of 120s unless you're causing untoward side effect. And as we see, as we get to be older, patients a lot of times don't feel well when they have, we know there's significant drug-drug interactions, but I would take it as a case-by-case basis. I would never say, look, you're 88, I'm going to treat you with a blood pressure of 150. If I can get that person's blood pressure to 130 or 125 with causing no untoward side effect, that's what I'm going to do. But if I start pushing it, and we follow these people, they go, you know what, doc, I feel terrible, I'm a little dizzy. Well, now I worry about this person feeling poorly, but I worry about them breaking a hip.
Sure.
And I've actually created a bigger problem by over-medicating these people.
Right. So this is not a table. You're not looking things up on a data table and saying, if, then, this, that, this number has to be there.
Yeah, so it's the
It's a
art
little
of
bit
medicine.
of, I have newt, toe frog.
I have...
I have newt, toe frog. It's like a recipe for something.
Okay, yeah. So, yeah, it is not an algorithmic approach. It is an individual approach, because what works for one person would not work for their twin brother. And it's a little bit of an art and a little bit of understanding that I'm looking at the greater good of that person. And we do have people we run in the 150s because they cannot tolerate. It doesn't mean that some people walk around and say, oh, this is normal for me. I've been treated with blood pressure of 150 my whole life. That's how I live. That's not the right answer. The right answer is, let's try to get your numbers down. Let's get it down gradually. And if we are able to, I'm more comfortable with that. But if we're not, I'm looking at the entire human being, not just the systolic blood pressure.
If someone says, I'm always 150 over 90,
we
can't really just say, oh, okay.
Yeah, my
We have
response
to
is
ask
you're
why.
always inadequately treated.
Yeah. And maybe if the question, well, why is that? Well, because we've tried to get it, when it gets to 149, I pass out.
Yes. If it's a 55 or 60-year-old person, I'm less inclined to follow that.
Not sure you're going to buy that.
Right. But if it's an 88-year-old, thin person who's not quite active, yeah, maybe that person does have more symptoms. So I would honestly tell you it would be a case-by-case basis. But the concept of this is where I live is really not a good answer.
So how about the other extreme? This gets us into, are there any different goals based on other disease processes? We had a particular patient that had heart failure, and their cardiologist was really struggling to control their heart failure symptoms, and the only way he could do it was to really push the blood pressure down. Right. So this patient really did live hypotensive.
Right.
So is it, if you see patients say, no, I always live low, is that any different?
So the first, I'll answer that in two ways. The first question is, how low is too low? When you're horizontal. That's too low. When you can't stand up.
Fair enough.
This is a very good example of why we overtreat people with hypertensives if they have heart failure, or we put people on antihypertensives even if they don't have hypertension. When someone has heart failure, your body knows that your ventricle is not meeting your metabolic needs. So your body releases adrenaline into your system. So your epinephrine and norepinephrine levels rise. That does two things. It causes actually vasoconstriction. So the natural response of heart failure is the adrenaline release, which actually causes increased systemic vascular resistance, which makes it harder for the heart to pump, and you create more heart failure.
Right.
The second, so we want to fix that by giving beta blockers. And actually carvedilol, which is an alpha and beta blocker, was the first drug approved for heart failure. I remember as a fellow, this was an unheard of, giving a beta blocker to a heart failure patient.
That was an absolute contraindication.
Right, and we would give them a pill and we watch them. And is this guy going to die and watch it? But now we titrate beta blockers. So beta blockers block that increased adrenaline, and ACE inhibitors and ARBs dilate the blood vessels. So we are counteracting the body's natural response to heart failure. And in doing so, we also lower blood pressure. So I like to see heart failure patients maximally treated to blood pressures of 100, 105. The carvedilol data is at 25 BID is most effective. We want to push up the lisinopril. So when there's actually other medications now which are taking the place of lisinopril, but conceptually it's the same. So we have a group of people who we will run hypotensive, and it's a fine balance between being symptomatically hypotensive and hypotensive enough to prevent heart failure exacerbation. So those people will be what would appear to be overtreated if you did not know they had heart failure.
How about renal disease?
Renal disease is tough because a lot of these medications will worsen renal function. The ACE inhibitors worsen renal function. The diuretics can worsen renal function. So A lot of times you have a situation in which you have to take a hit to kidney function to reduce risk. But it's a fine balance between, having the nephrologist look at this. The biggest problem with renal failure is the underlying process which is causing renal failure. So taking out of the people who have glomerulonephritis or other autoimmune issues or primary kidney diseases, the biggest problem with renal failure is hypertension, diabetes. So we try to fix the underlying problems. And in some cases, for type 1 diabetes and type 2 diabetes, we use the ARBs and the ACE inhibitors to protect the kidney also from hyperglycemia. So at certain levels, and this is sort of beyond this discussion, but these medications are beneficial to the kidneys. At other levels, these medications are actually harmful to the kidneys. So it's a very fine balance. And again, you've got to look at the overall good, because if you have someone who has heart failure and they're in stage 4 heart, they can't breathe, they're functional class 4 or 3, you have to get these people on diuretics, you have to get them on angiotensin receptor blockers or ACE inhibitors, but you are going to pay for it on the kidney end, at the other end of the spectrum.
So when our CHPs go out and see patients with hypertension, is there anything in particular that you think they need to focus on, any priorities, particularly keeping in mind that these are not going to be patients just with hypertension?
Right. So I would emphasize one clear point, and that is we don't want to treat hypertension the way we treat diabetes. We don't see a blood pressure and treat accordingly. We want to have enough hypertensive medication in that person's system to weather the ups and downs of the blood pressure. Because if someone doesn't have a constant blood pressure throughout the day, it's going to be up and down. And if I take readings multiple times a day, I'm going to have a scattergram. And we want to plot sort of the mean through that.
So let me interrupt you there, because I think that's incredibly important. Let's take our stereotypical, triathlete who also happens to have really good physiology, no medical problems whatsoever, no underlying undiagnosed medical. They truly are healthy. And you take their blood pressure 15 times a day. Is it going to be 120 over 80?
No, it's going to be up and down, up and down. In fact, that person comes in the office to see me and they're scared. They're 150 over 90. And I purposely don't treat. What I will do in that case is say, look, go out and get a blood pressure cuff. Check your blood pressure twice a day at different times. Jot it down. I'm going to measure your thickness of your ventricle. And if your blood pressure is consistently elevated and or you have evidence of left ventricular hypertrophy, now I'm going to give you the diagnosis of hypertension.
So when we're talking about hypertension, it's not a single value.
It is absolutely not a single value.
Great.
And so and along those lines, we don't say, oh, your blood pressure is 160, here's the dose of medicine you get. In rare cases we do, but in 99% we don't. So what I guess the take-home message to the community paramedic would be, if you are seeing someone and they are consistently elevated, and you're reviewing home blood pressure readings, that's the person who needs a hypertensive antihypertensive therapy adjustment. So when we see these people, one reading is inadequate. It needs to be a series of readings, and the medication has to be titrated enough so that the maximum blood pressure is controlled and we're not bottoming them out. It is a blend. And sometimes you have to give it up on one end, because as we age, the arteries have become stiff and blood pressure is transmitted differently, and you do have bigger swings. But if I will sometimes trade off, we have people who are bottoming out, we'll run them a little bit higher. People who don't bottom out, we'll run them a little bit lower. So I guess the take-home message is the titration should not be done on a daily basis. It is 3 to 4 weeks of readings, a medication adjustment, let things equilibrate, 3 to 4 weeks of readings, and if it's done that way, you get a good sense of what's going on, and it's much easier and more tolerable to the patient.
Chronic disease, the management's a bit on the chronic side too. This takes time.
Exactly.
Just to wrap this up, is there anything about the treatment of hypertension, particularly whether you think our community paramedics need to know this to help their patients, or something that we need to know to help ourselves? Anything we haven't talked about yet?
I think we've touched on most things. I think the biggest take-home points are understanding several different major issues. That there's hypertension is treated differently when there's significant underlying comorbidities, especially heart failure. There's no right answer to any given person as to what drugs are effective. But I have yet to find a patient who is intolerant to everything. And sometimes it takes months, but with the right titration and the right follow-up, universally we can find a combination of drugs that is effective, isn't cost prohibitive, and doesn't cause significant side effects. And I believe the biggest take-home message is elevated blood pressure by itself without any clinical symptomatology is not an emergency. It's the need for I saw a lady in the office yesterday who had a systolic blood pressure of 190 and felt fine. And everyone wanted to send her to the emergency room. I said, look, this lady is fine. She can see well. She's mentating well. So when we see blood pressure like that, it clearly needs to be investigated. Now, a lot of times the person's stressed out. Maybe they're in pain. Maybe they took some Sudafed, and these people need to be sort of flushed out a little bit. Maybe their medicines need to be adjusted, but we don't need to take them to the emergency department, which is very different than the person who has a systolic blood pressure of 190, who's confused, has blurry vision,
crushing chest pain,
things of that
can't
nature.
breathe.
Right.
So God, as an ER doc, God bless you for saying that. I was taking care of a patient yesterday who was, this is just such a great story, I got to share. He was in the pain clinic for his chronic pain.
Mm-hmm.
He had an exacerbation. He tripped, fell, oh my God, the pain is horrible. People got there, and so what are they going to do? They took his blood pressure, and it's 200.
Right.
Come
Yep.
to the emergency department.
Yep.
So he came to the emergency department, and he had some chest pain. But it turns out when you ask him, this is the exact same chest pain I've had every single day for the past 20 years. This is nothing abnormal here. EKG is normal, trope is negative, and he's in pain. Treat him with morphine. His blood pressure comes down. I discharge him. He goes off to his next doctor's appointment. Morphine wears off. He's in pain again. His blood pressure's up. And I'm looking at the board, and I see his name again. I'm like, why is he back here? Yep. Awesome.
Another example of that, which we see all the time, is, and I can personally vouch for this, you go get a dental procedure. And you're sitting in the chair, you're in pain.
Experienced hypertension recently,
You're
have
in
you?
pain, you're freaked out of the machines that are there,
Right,
the drills,
and the
and they
noises.
take your blood pressure, and it's 140/90.
Well, we can't do this. We can't do this procedure.
So it is an anxiety-provoking event which will drive blood pressure. So the take-home message is look at the big picture.
Yeah. I think that is a great place to end. Dr. Scheinberg, thank you so much.
My pleasure.
Welcome to the team, and I really
Thank you.
appreciate the help.
I look forward to working with you more. Thanks.